Obviously, had I known that these are my regularly scheduled August town meetings, we usually don't have to rent a hall. We usually get City Hall for free. But I think democracy is alive and well. Given the turnouts I've been getting, people are incredibly concerned about the future of our country, particularly focused on healthcare. Just a few housekeeping issues. I want to thank the City of Eugene, who was our original host, but also the city for providing help with the meeting tonight, to the Eugene Police, for the Fire Marshal's Office, and I want to thank the staff at the Eugene Hilton. Should have a handout on your chair, or it should have been handed to you by on the way in, and there's two things. One is a small sheet, which is for your comments if you don't get to ask a question, and we will endeavor to answer all of them, but I'm going to tell you it's going to take a little while because we're getting a lot of comments by various ways, not only with my meetings. And secondly, if you want to participate, there's a different venue that I used last year people really liked, but Oregon has a particular restriction on it, and that is it would be called a telephone town hall, a giant conference call. And then there's a way to queue up for questions, and I will answer questions during the giant conference call. That'll be on September 3rd. But under Oregon law, if you are on the do not call list, you won't get a call. So right now, the only people we're calling are registered voters who are not on the do not call list. And out of the 300 and some odd thousand voters in my district, there's only 70,000 who aren't on the do not call list. Hey, I'm on the do not call list, so it's like. What I would say is that if you want to participate in that, put down your phone number and sign it, and we will have enough time to get you input. And then the other sheet, common myths, and a few points about healthcare reform. And then finally, this is the bucket. I've tried to think of a fair way to in a totally impartial way to call on people, and that's the way we're doing it. It worked well this morning up at Cottage Grove. I'll draw 3 tickets at a time, call out 3 numbers, and there'll be people circulating the room with microphones. Just raise your hand or shout out like you're an auction or something if I call your number, and they will come up to you, and that way we can move along really quickly and not have gaps while we're moving the microphones around. We have 4 mics. We should be able to move that and cover a lot of questions. Let's get started then. As I said, this is a regularly scheduled town hall. You're not restricted to discussing health care. I've had other issues come up. There are other things going on that affect our nation, and you're free to do that if you're called upon. This is HR 3200. It's become somewhat infamous. I have read it to get that out of the way. But it's more complicated than that, obviously. The bill has, since it was introduced, think of that as a rough draft. It's gone through 3 committees in the House. Each of them has made individual changes. There are important changes that I've been involved in negotiating, and I'll cover that briefly. Oregon is a state that is a very efficient provider of medical care, and we are penalized because of that. Our reimbursement rates under Medicare are some of the lowest in the nation, and many seniors have trouble finding a physician who wants to take new Medicare patients because of the low reimbursement rate. There are 16 other states in the same boat with us. We're relatively small states, Minnesota, the Dakotas, and others, but we all banded together at the outset because one of the provisions in the bill is to set up a health insurance exchange where people who don't have insurance or are looking for more affordable insurance can go to buy insurance, and includes a public plan option. Now, the public plan option in this draft would have been based on Medicare reimbursement rates. And we said, look, not only is the problem already for our seniors, but if you create a new plan and you say the docs and the hospitals will get the rates that Medicare is paying today in Oregon, they're going to have insurance and they won't get anyone to see them. So that we drew a line in the sand, and we have negotiated language within 2 years before this bill would go into effect to get changes in Medicare, which means some of the very, very high-cost states that are very inefficient providers of medical care in the East are going to come down, and Oregon and 16 other states are going to go up, and we're going to fix that reimbursement system before we go forward. just a few more points. You know, we have a system today that's a mixed system. We have 160 million people, give or take, given the bad economy, who get their insurance through their employer. We have 44 million people who are on Medicare. We have about 12 million vets getting veterans care, 3 million people in the active military. We have a number of people in private pay with individual insurance plans. And then we have somewhere between 45 and 50 million people who don't have health insurance. They estimate that 70% of the people who are uninsured are actually working. But many of them are working in small businesses. I ran into a small business owner on my way over earlier this afternoon, and he said that the increase in his insurance rate next year is after struggling in business for 24 years, may put him out of business. So small businesses are struggling, and there are a number of provisions in this bill to help small businesses access affordable insurance for themselves and their employees. There are other problems with insurance other than the cost. I've got a chart here that shows health insurance costs have doubled over the last decade, and they're on a trend to do it again. That would mean 10 years from today, a good policy for a family of 4 would cost about $24,000, $25,000 a year. There are not many businesses or individuals who can afford that, and that's something we've got to deal with here. So cost is one major factor. There are other problems with private insurance as it's constituted. There's something called prior existing condition, where they will exclude any known problem you have, or they will exclude you altogether from coverage. This legislation would ban that practice by the insurance industry. It would do away with something else I hadn't heard a lot about, but came out in hearings this spring, which is really a kind of a nasty practice, and it's called rescissions, where people actually have insurance, they've been paying their insurance, and when they get a serious chronic disease like leukemia or cancer, some insurance companies, particularly in California, had special teams of benefit agents they would put on those cases, and you think, well, isn't that nice? No, they're not going on the case to help you get your benefits. They're going to go through your medical record and find a reason to disallow you, and they actually were paid bonuses to do that. There was a classic example of a woman who testified for Congress under oath. It's been documented by her physician that she had visited her dermatologist for acne. They said it was skin cancer. She had breast cancer, therefore they disqualified her from coverage and said they wouldn't pay for a mastectomy to keep her alive. The local member of Congress, a Republican, finally talked to the CEO of the company 6 months later and got that resolved. It shouldn't be that way. This bill outlaws rescissions unless you committed fraud in applying for your insurance. No more of those kind of details. It does a couple of other things that I think are very important. No matter how well you think you've provided for yourself, medical care is astronomically expensive. And this would put under all covered people, you would have a $5,000 individual cap under any public or private policy, a $10,000 individual cap for a family on an annual basis. No lifetime limits, which is a little thing hidden in most people's policies that nobody knows about, but there is somewhere probably in your policy a lifetime limit, meaning if you have a catastrophic accident, really expensive care, and you've been paying for the policy for 30 years, they'll say, well, gee, I'm sorry, you used it all up. You had a $500,000 lifetime limit. That is prohibited under this legislation. No lifetime limit. Now, the key thing that seems to have generated the most controversy, and after this I'll be quiet, we'll get on to questions, is the whole idea of a health insurance exchange and a public plan option. Now, the health insurance exchange would have 3 levels of benefits: a standard minimum kind of benefit, mid-tier benefit, and then a higher tier benefit. They would all have to be at their base standard. They could add, a private company could add over and above that if they thought they could attract clients or they could afford it, services. But they have to provide a certain level of service at the minimum, at the mid-level, and at the top. So everybody would know what they were buying. But the idea is to try and get those policies offered in a very affordable way, which is the idea of the public plan option, which is to say, here's a policy that covers those same services, and this will be offered at the lowest cost possible to try and get the insurance industry to hold down costs. One thing most people don't know, or so many don't know, is the insurance industry in America is exempt from antitrust law. That means they can and do collude. They get together to just decide what rates they're going to charge, that's legal. They get together to decide what states they're going to sell in, that's legal or not sell in, what communities they're going to sell in or not sell in, what conditions they're going to exclude or not exclude. All that is legal. It's not legal if you're in any other form of business in America except professional baseball. You know, since I've been in Congress, I inherited a bill from a wonderful gentleman, Senator William Proxmire, used to give out the Golden Police Awards, anybody who remembers that, but great guy. He introduced this bill the first year I was in Congress, and he ended up, I was really interested in it. It turned out no one else wanted to sponsor it in the House. I found out later why, because the insurance industry is not very forgiving of these things. But I co-sponsored the bill, I've reintroduced it this year, and that is, I feel, another way to help keep down costs, and I'm trying to offer that as an amendment to the bill. So with that, we're going to go to the questions here, and as I said, I'll read off three. I'm going to read off the last 3 digits because we have just over 1,000 people in here, hopefully not too many or the fire marshal will get upset. It's the biggest room we could find, fairly close to City Hall. And raise your hand or shout out and someone will move toward you with a microphone. 951, 950, and 306. Okay? Anybody? Shout out. There's a hand there. Good.
You mentioned that health insurance companies are the only business that there are no antitrust laws for?
They are specifically exempt under McCarran-Ferguson, yes.
So my question is, why hasn't Congress done something about that? Number two, you sounded like you were telling us that no limits, some policies have $1 million, some $2, but now we're going to pay for everything up to $5 million maybe, and we're not going to have any limits on pre-existing conditions. How are we going to survive as a country economically if it sounds like we're going to just take care of everybody with the government doing it? We haven't done very well on Medicare. Medicare is bankrupting this country. Everybody says, if you have Medicare, then you have the...
Come on, be quiet, let her finish. Go ahead.
Everyone says, if you have Medicare and you like what Medicare does, that's the government running an insurance company. And my understanding is, I mean, I keep seeing these ads on the television. Get a wheelchair. You don't have to pay $1 for it. Medicare pays 100%. Well, how long can we do that? Thank you.
Okay. Thank you. On antitrust, all I can say is the insurance industry got the exemption in 1946, before I was born, and you know, William Proxmire, I'm sure, had been proposing to take away their antitrust exemption before I came to Congress. I've been proposing it for quite some time. They're a very powerful industry. I once, quick diversion, had the CEOs of all the airlines before the Aviation Committee, which I'm on. We were taking their terrorism risk after 9/11, but they were there saying, well, you know, but we also have these other huge run-up in our insurance costs. And I said, well, that's kind of odd. Why is that? Because, you know, you haven't had any accidents in the last year. And they said, well, we don't know. You know, but it went from like 200 million aggregate to over $1 billion for our liability insurance outside of terrorism risk, which the government took. And so I explained to them my bill about, you know, antitrust and said, you guys have to compete. You know, you raise the rates and someone else doesn't, you bring it back down again. I mean, you've got to compete. You can't collude. You can't go to each other and do that. And so I said, how about supporting my bill to make the insurance industry work the same way you did? And I didn't get any volunteers from the CEOs of the airlines. Everybody's a little bit afraid of the insurance industry in a lot of ways. It's a very powerful industry. So hopefully it will be allowed. When I brought it up leading up to this, you know, the break this summer, and I brought it up in caucus, everybody said, that's a great idea. And then leadership would say to me, well, but it'll never pass. And I said, well, how about just letting me offer the amendment? If it crashes and burns, it's my problem, not yours. But I would find it hard for anyone, the most ardent free market advocate, you know, on the Republican side of the aisle, to say, we think the insurance industry should have special privileges and collude, unlike other businesses. I don't see how people would argue to keep it. I mean, the industry would, but I don't think members of Congress could. So on Medicare, Medicare has problems. Medicare has 44 million people on it. Medicare was paid for in part by a trust fund, Part A, which everybody pays into out of all of their earnings. It doesn't have a cap like Social Security, so you pay the Medicare tax on all of your earnings, unlike Social Security, which is capped a little over 100,000. That's been paid for Part A. That's a trust fund. Part B is based in part in premiums paid by seniors, and about 2/3 of it, or a little more than 2/3, is paid for annually with appropriations. Part D, which was just added on, very expensive program, Medicare prescription, so-called prescription drug benefit, costs about $50 billion a year. So that's driving Medicare trust fund toward exhaustion very quickly. I voted against Part D, not because I don't think seniors need a prescription drug benefit, they do, but because it was written by the pharmaceutical industry. It subsidizes both pharmaceuticals and insurance, and then gives seniors a donut hole and not great coverage at a cost of $50 billion a year. If we repealed that, negotiated lower drug prices like every other nation on earth does with the pharmaceutical industry, we could save most of that money. And then Medicare wouldn't have a trust fund problem. But you also pointed to durable medical equipment, and I'm not going to defend the way Medicare acquires durable medical equipment. There's been scandal after scandal after scandal. We propose reforms this year to get into a competitive bidding process there instead of the current process. And there are problems, as you mentioned, particularly the wheelchair or whatever, with durable medical equipment. And then one other point you made. Lifting the lifetime cap does not mean that every procedure is provided to everybody. It does not say that you have to give a heart-lung transplant to somebody. There will still be exclusions on these policies, things that won't be covered, that aren't covered today by many policies. So it isn't everything for everybody. Everybody's going to have to pay something for it. And what will happen is there's a large group of young people who feel fairly invulnerable, like I did when I was young, and they don't have insurance. They're going to have insurance, and they will be sharing the risk with everybody, and that's part of the reason why some of the insurers and others out there support this, is they say, oh, look, we're going to get a lot of people who are very low risk, and our hope is we get those people channeled into these exchanges. Those will be very low cost premiums because they won't be high-risk plans, but they will have a few high-risk people in them. This is the other thing is, of course, today, we don't deny anybody in America emergency medical care or critical medical care if you're deathly ill. But you go to the emergency room to get it. It's the most expensive care possible. And guess what? It's not free. So everybody who has insurance is paying, the average in Oregon is $1,400 a year per policy for unreimbursed care and the increase in charges to pay for them. And that problem would go away. So actually, there's gains and losses here to make it affordable. Thank you. There were two other numbers I called. Did either of those have a response?
How about getting rid of the fraud like
okay. So here we go. We'll go to 781028. These are the last three digits. And 029. I got to mix these up more. So 781-028-029. Raise a hand. There's a hand there. Ed, I think a gentleman there. Way down back, there's a person way down back on the wall. And there was a gentleman in there with a red shirt, I think. But
Hi. I was wondering what the constitutional basis for this piece of legislation is. What constitutional provision justifies the
it's under the Commerce Clause of the Constitution, which justifies a whole host of things that the federal government does. These things were not particularly anticipated when the Constitution was written, but I've had some people pursue that point, and I said, if you were right, that unconstitutional for us to provide medical care, then we would have to repeal Medicare, and I think that would be a huge problem. So the court has ruled numerous times, both conservative and liberal courts, on the constitutionality of the issue regarding medical insurance. So. Another gentleman? What I think I find is that some people think they're going to ask a question and then don't. But okay, 477, 467, and 646. Shout out, raise your hand. There's someone over there, right there, holding a cup up. Woman in the middle of that row, Frank. The other two numbers, anybody? So we can get these questions moving quicker. There's someone right in the middle with their hand up, okay? Okay, go right ahead.
I just wondered, Bill McGuire, the CEO of the insurance company that ARP had, made almost $2 billion. And when you think that ARP is designed to help elderly people, isn't there a way that they can put a cap on the CEOs of the insurance company's wages so that that money can be lowered for the premiums for everybody? Because they don't need that. How much money does one person need to live?
Well, private companies that are not taking taxpayer bailouts are free to pay what they will. They are responsible to their board of directors, their stockholders, and we're trying to improve board of directors, stockholders' rights, because right now the way it works in most corporations is if the stockholders vote to limit a CEO's salary, if they manage to get an initiative on the annual ballot, even if they win a majority, it's not binding. We're trying to reform some of the corporate governance. He hadn't heard about that individual, but another fellow who was the head of United Healthcare, the largest health insurance provider, he was found to have done a little deal on his stock options, insider trading. He had to pay back $600 million and pay a $7 million fine, so you think he might be hurting, but he still had $800 million of stock options that he took when he left the company. So there are some problems there, but again, we need to reform some of the corporate governance. We can't begin regulating the salaries of private institutions. So, yes?
I saw on your website that you are for the Seneca wood burning site in Eugene.
No, but go ahead.
Oh, but never mind.
I think there's a little confusion between a public policy and an individual issue. Right now, federal law says that a private company can get tax benefits for biomass. It says on federal land you can't get tax benefits for biomass. I want to improve the health of the federal forest. We can't afford to do the fuel reduction and the thinning that's needed. And what we do, the first prescription under the so-called stimulus bill for a fuel reduction in my district was down in southern Oregon. And what they're going to do is, and they have done, is they've gone in there and thinned that forest, which it sorely needed, and they've put the stuff into giant slash piles and they'll burn it next winter in a very dirty way. I would prefer to remove that biomass out of the federal forest, get a cheaper price to have the work done because someone's getting some value out of it, and burn it in a contained environment with scrubbers. I'm not choosing any place to do this, and you know, that's what I want to do with the federal lands. Private companies can already do it, and the process is you know, being handled through LRAP, and they've extended the comment period. So I encourage anybody who's concerned to get involved. So there's over there, yes.
Representative DeFazio, my name is Ron Jansen. I am very concerned about HR 236. If I've got my numbers right, that is Senior Citizen Protection Act that's going to be coming on voting this September. Am I correct?
There's been about 4,000 bills introduced, and that one doesn't quite ring a bell. If you can maybe give me a little more description.
Well, in other words, it protects us from losing what we have.
I'm sorry, the mic went off when you said that.
I say that it's protecting the senior citizens, our Social Security, our different things that we have now in effect. And we stand a chance, as I understand, losing this. But this Protection Act, I don't know too much about, other than it's got a name and a number, and I took the information I had to your office. Okay. Phyllis has it.
All right. Well, go ahead.
That was my question.
Okay. Like I said, it's been about 4,000 bills introduced. I'm not familiar with that one, but let me give a couple of assurances here. Under this bill, actually, some people have seen numbers. The Congressional Budget Office, which is a pretty hard-headed bunch of people who've scored the bill to be pretty expensive, has actually said the bill will save, not from reducing benefits, but save from the current overpayments that are going to private insurers under Medicare Advantage. It'll save on a number of other reforms in the bill quite a bit of money for Medicare, and actually Medicare benefits are going to be improved. We're going to get a higher reimbursement rate for Medicare in Oregon, which will give you better access to physicians. We're going to require that all of the private and public plans provide annual physicals, mammography, wellness, those sorts of things to try and prevent disease from progressing. Those will be added to Medicare as well as the other private and public plans. So, Medicare actually is not threatened by this legislation, although there's a lot of concern about that. Social Security is not at issue here. I'm an expert in Social Security, have been a long time. Social Security in 2039, if we can honor the trust fund of Social Security, which is questionable given the levels of debt we're running up, but if we can honor the trust funds of Social Security and repay the debt, the money we borrowed from them, Social Security can pay 100% of benefits till 2039, and after 2039 they can pay somewhere around 75, 78%. So it's got a problem starting in 30 years that needs to be addressed. The easiest way to address it is say, you lift the cap on Social Security wages, and you would pay Social Security tax on all your wages, and that would fix the problem. Right now, after $110,000, you don't pay. And whether that bill has specifics like that, I don't know, but I will get a look at it. I'll get that from Phyllis. Okay, we have 486, 650, and 640. 650, 486, 640. Okay, we get any hands on that?
Are you ready
okay.
for a question?
Yes.
Okay. I have not heard anything on the healthcare reform on what or if any provisions are going to be made for mental health services. Could you expand or tell us something about that?
I would assume we've just gone through a big mental health. We are not at that level of specificity yet. As I said, it's a work in progress. I would assume that we will get full coverage of mental health, since we just went through a huge fight over many years in Washington, D.C. to get to national mental health parity legislation. Oregon has had it for a number of years as a state, and I don't expect we're going to back away from that. We found, despite the fact that for years people said, oh my gosh, if you give mental health benefits, it'll drive the cost of insurance up astronomically. It's actually worked out quite well. Insurance has gone up an increment, generally less than 1%, for the cost of the mental health parity. Employers are very happy with decrease in absenteeism, and individuals are having better lives. So I don't see us backing away from that, but we haven't gotten to that level of specificity yet, ma'am. So yes, go right ahead.
First of all, I want to say, I hope you stay in office, Peter. I hope you don't go somewhere else. This is going off. I want to speak for immigrant rights. We need immigrant rights reform. We have hundreds of thousands of people crossing the border because of our failed economic policies, our NAFTA, our free trade policies that are sending subsidized corn down and causing the ending of local farms, small farms all over Mexico, and the villages are being vacated by the strong adults who are able to come here and who come and risk their lives in order to get money to send back. And of course, Mexico is not the only country that is involved. And the businesses here, they can't get visas. Visas go to the people who are professional, who have high technical abilities. They don't go to all these swarms of people who come to do the labor in the slaughterhouses, in the farms, in the big farms here in the United States. And the owners of the slaughterhouses like the fact that there are undocumented people who will not stick up for their rights and cannot unionize. I would like you to speak on this question of immigrant rights reform. Thank you.
Thank you. Well, first, we have problems on both sides of the border that have caused these problems. I voted against NAFTA. At the time, that was not a popular vote. Predicted many of these problems. In fact, sometimes the political spectrum looks more like a horseshoe or something than it does a line. And Ron Paul and I, if you know Ron Paul, have tried to repeal NAFTA. We didn't get that many votes, but we've tried, and we'll try again, or at least get it renegotiated in a way that makes sense for people on both sides of the border. This has been a tremendous convenience for big agriculture and other corporate interests in the U.S. The Wall Street Journal for years has editorialized for open borders, the idea of bringing in massive influx of labor to try and break the unions in here. The slaughterhouses were unionized. Not a great job, but they paid pretty darn good wages. And they were busted by companies bussing people up illegally. And now it's a place where people are abused, many of whom are not in the United States legally, and have trouble accessing health care if they get injured, or they're ineligible for workers' compensation and other things because of their lack of status. So this is a huge problem. I think the president has recognized it, says he wants to deal with it in a comprehensive way, but we've kind of got a full plate right now between the health care bill. I've tried to do the 6-year transportation bill is due on October 1st. Just got reports today that we're going to see a huge drop off in construction spending next year. Not something we need. If we can't pass a long-term bill, I'm trying to convince the administration to do that. There's a pretty long queue, but he has said that he has convened some meetings in Washington to begin to work toward a comprehensive reform. The problem, and it's got to go a long way, and it has to deal with both trade policy, labor policy, and immigration policy to solve these issues. And I'm not sure, how quickly or how soon we're going to get there. Right now, we're pretty embroiled in this one particular debate, but I recognize the problems. Other questions on that queue? Okay, we'll go to 109. I'm not mixing these things up. It doesn't matter. 109, 110, and 111. Now I'm really going to mix them up. I couldn't do that if I tried 100 times. So 109, 110, 111. Anybody? Shout out. Okay, all right. Quickly then. 930. 779. Raise your hand, shout out. 930-779. 780. Bingo, all right. Go for it. Where are you? Right there? Oh, you didn't have it? Okay. Here we go. There's a gentleman there.
Okay, well, thank you. I never won a lottery. I guess this is the first time. I'm going to address this with two interesting past experiences. Number one, I spent 6 years behind the Iron Curtain country, and I know what social medicine is, and I know what socialism is, and you ain't seen nothing yet. This is not even close. Second, I'm a physician. I started practicing in the 1970s. Now, my question, we're talking about affordable health care and so forth. There always will be people who just don't have the money. And I think the program is going to fail if those who cannot afford it will not have insurance, will not have coverage, because then they end up in emergency room just like you mentioned. There has to be a coverage for everybody. If maybe it's going to be means tested, but the lowest echelon of income bracket has to have coverage, otherwise the whole thing fails.
Okay. I just give a couple of numbers here. We don't want to get buried in the details because, again, this is a work in progress. But as of now, in the House version of the bill, you would get subsidies up to 400% of the poverty level in acquiring your insurance. And for an individual at 133% of the poverty level, you would pay $18 a month. That's someone who earns $14,000 a year. That would be a pretty good deal for that person to get into a good group health plan. And for a family of 4, and obviously if you have absolutely no income or no resources, then you would fall under the Medicaid program, which will still exist. But under the family of 4, let's say at 200% of the federal poverty level, 44,000, I run into a lot of people having trouble who are in that kind of category. They could get a good group health plan for their family for $200 a month under this proposal. It's quite affordable health care. Others in that run of tickets there, okay, 490, 550, and 491. Okay, 491, 490, 550.
Hello, Mr. DeFazio. I actually have a slightly different...
Okay, I'm trying
right
to...
here.
Oh, there, okay, great. It's a big room.
I have a way that we can save some administrative costs in healthcare.
Okay.
I work in the healthcare field, and whenever we have to credential a physician with an insurance company, it is a nightmare. There are so many different applications for all of the different insurance companies, and then you have to re-credential them every 3 months. This costs a lot of money and it's wasted time. So I hope that somewhere in the reform there can be a universal application for all of the insurance companies and that it is sent into a database that is then accessible for all the insurance companies. Thank you.
Thank you. If any of you talk to your doctor like I have, I mean, sometimes I go to the doctor to get things fixed and he thinks it's his time to lobby. So I get longer appointments than most. But he points out he has 6 clerical staff, 2 docs, 1 physician's assistant, 2 nurses. So as many clerical staff as he does healthcare providers in the office. This bill actually, I think, proposes a good thing there, which is standardized billing across all private and public insurance. Same coding, standardized billing. And then, obviously, it's supposed to move toward electronic standardized billing as soon as possible. You might remember that part of the stimulus, I didn't really think it belonged in the stimulus, because it hasn't been spent yet and we don't even know how we're going to get there yet, but there was money for healthcare IT to begin to implement this idea. But we are going there, but it's an excellent suggestion. That's not where we want to be spending our precious healthcare dollars. So any other in that, yes, right there, yes sir.
I guess I'm more concerned with the big picture still. And could you explain how you would suggest that we accomplish the repayment of what I consider to be reckless spending by both Congress, prompted by the administration, that they've engaged in with bailouts and takeovers and tax and cap and tax, and now the infliction of the national health care, other than a huge tax increase on everyone, or drastic cutting of expenses, which I don't think is going to happen with Congress, or printing of money resulting in huge runaway inflation.
Okay. Those are all very serious issues, and I've worried about those things for a long time. I was a balanced budget Democrat back in the 80s when you weren't, when it wasn't fashionable, we did achieve real budget surpluses, not taking the Social Security surplus and spending it, but real surpluses for 2 years in 99 and 2000. Unfortunately, that was very ephemeral. There were people at that time talking, oh gosh, we'll pay off our debt in 10 years, then what will we do? And we immediately got into cutting taxes, a war where for the first time in history we got into a war, which I thought was an unnecessary war in Iraq, and cut taxes as we went into the war. So we doubled our debt between 2000 and 2008. Then comes the TARP in the fall, and that was a bipartisan problem. They get stampeded. Henry Paulson stampeded the president, and the president stampeded the Democratic leaders of Congress, and they all rushed to bail out Wall Street. I said, look, I don't know that this is Armageddon financially, but I'm dubious about whether it's as big as you're saying we need to throw all this money at these firms on Wall Street. But if we have to do that, how about we have a plan that they pay it back themselves? And I offered that. We had a minuscule securities transfer tax from 1916 to 1966, 1/10 of 1%, would have paid off the TARP bailout in 4 years. A 1/10 of 1% tax on securities transfer. I thought that would be a more fair way than borrowing against our future. That would have reduced the number we're dealing with by $700 billion. I voted against the stimulus because I have a rule in approaching these things. I'm not opposed to putting people back to work, making some investments and put people to work. I have my own prejudices about what works. And to me, it's roads, bridges, highways, transit systems, sewer systems, water systems, schools. It's investments that are going to last. It's education, too. And so what I said as we approach that bill, let's do things where if your grandkid asks in 30 years, why am I still paying for that money you borrowed back there in 08 or 09, you can say, well, that bridge you drove over today, we built that. Or, remember your education? We stopped huge cutbacks in public education through it. Those are investments in the future. A lot of the stuff in there was already tried. For the life of me, I don't know why we did it again. Tax cuts. We borrowed $340 billion to give mostly individuals $12 a week tax cut. Now, if you're unemployed, that's not going to help you get a job. It's not going to rebuild America. It's not going to fill in a pothole, but that's a lot of money to borrow. But you know, that and other tax cuts were included in the bill. There's other dubious spending. So I wanted to have something much more oriented toward investment. One quick story. I go up to Sweet Home in my district. They had me come up there because they needed a new water system. I'm in the water plant. It's kind of an interesting it has a whole bunch of levels that go down like this. It's full of sand and gravel. The water comes in the top. By the time it gets to the bottom, you can drink it. But it's a beautiful building too. It's not like a factory. And I'm looking around and finally I said, so who built this? And they said, oh, it was built by the WPA. And it still works. And that same day I went out to see a Head Start program, which was in a little old schoolhouse that isn't a school for public school anymore, but it's for Head Start. And they showed me the plaque built by the WPA. Those are the kind of investments we should have been making in the stimulus to put people to work that will provide benefits for generations to come, not what we did. So, and then finally, quickly on your third point, and you know, I'm happy to talk about something other than healthcare for a change, so I am going to answer all three of your points, is the issue of cap and trade. You know, we had horrible problems in America with our rivers back in the 60s. We had rivers back east that burned, the Willamette was an open sewer, and we said, not going to do that anymore. And we did it through the Clean Water Act and regulation, and what we did is we went out and said, we inventoried all the pollution, gave people schedules and said, you're going to stop dumping stuff in the river, you got a schedule, and by the way, we'll be back, and if you don't meet the schedule, we're going to fine you. I believe that we do have a problem, and you may disagree in dealing with with climate change and carbon dioxide emissions, but I think there's a much more rational, lower cost way of doing it than involving Wall Street, and cap and trade was first proposed by Enron. Anybody remember Enron? Bankrupt, Ken Lay's gone, but you know, Enron, they first proposed cap and trade as far as anybody can tell. And I have on my website, if you visit there, hysterical statements from people on Wall Street saying, this is going to be bigger than the financial services, this is going to be so lucrative you can't believe it. In Europe, $60 billion a year of costs on their allocations and their offsets, and higher carbon emissions. So what did they do? Well, some people are getting rich, that's true, a few traders, but the people of Europe are paying more for everything and they haven't lowered their carbon. I don't want to replicate that here, and the bill that was offered in the House will give us the same system. So, and I sponsored a bill by Jim McDermott of Washington, which takes the good old-fashioned regulatory approach to deal with it. 474-424-778. 474-424-778. Boy, this is a dead crap. All right, we'll keep trying. I wish, you know. Oh, we got one. All right, here we go. Yes, ma'am. The microphone's coming. Anybody else in that series? Raise your hands.
I'm sorry. I mean, I was waving my hand. My number was not called.
Well, I'm going to stick to the system unless it totally breaks down, because it's a very... Okay. I know, but then we'll get 1,000 hands, and then people say, "Oh, you're looking left." This is my 10th of these town halls, and people say, "You're only looking left, you're only looking right, you're only looking at the back, the front," and I just decided to do it this way to at least absorb that kind of. You only count on people you know. I've got a room of 1,000 people, and I pick out. So this works better from my perspective. 498-660-495. There's one in the middle. Okay, move toward that person since no one else raised their hand. I'll read another one. 585. 585. Okay. We're gonna 641. Get her microphone. 641. I'm continuing. Anybody? Raise your hand. I think what's happened is people are taking tickets who didn't want to ask questions, and we've got to be more clear with folks. 677. 677. Okay, go ahead, ma'am.
I have a question concerning your opinion of House Bill 676, single payer. Is there any chance that this can be given an honest discussion of its merits sometime in Congress? It's been just rolled over, and I think the American public deserves a discussion in Congress about the benefits of this bill. Thank you.
Well, the president started from a place where he recognized that today we have, about 80% of the population has health care coverage of one form or another, and many of them are pretty good with it if they can keep it. He decided to improve it and make sure they could keep it, and then to figure out a way to cover the other part of our society who aren't covered by health insurance, to give them better and regular access. And that's where the exchange and the public plan option were born. If you note the controversy around the public plan option, I would have had to probably, if we wanted to discuss tonight a single payer, we probably would have been at Autzen Stadium, and my budget couldn't afford that. But I'm not adverse to discussing anything that'll fix this problem. But the issue is when that many people already have coverage and you have a system that works pretty well, the conversion would be wrenching. I think the president said in an honest moment, he said, look, if I were starting a new country today, and I was going to put in place a way to pay for health care, I would move toward a single payer. But so he's trying to deal with the reality of where the country is at, where we've evolved to, and how we can make it a lot better than it is. And we're still engaged in that debate. Whether or not, the Senate doesn't even want to go along with a public plan option. They say they want co-ops. I just read a GAO report, the General Government Accounting Office, and they say that the few states that have co-ops, they have not kept costs down, that they don't do it. So we're engaged in a very robust fight over the public plan option, which the House probably will include, not a done deal, and it looks like the Senate might not. And how this all gets resolved is going to be an interesting fall and winter and maybe spring and maybe summer and who knows. It's been. This bill, as written, doesn't go into effect till 2013, which I think is way too long. So, we need to do something sooner than that. So taking a little bit of time to get it right is not wrong. It was first, and I used to go around saying, Roosevelt first proposed this, and my history was a little remiss. Well, I got the right name, but I got the wrong Roosevelt. It was actually Teddy Roosevelt as the Bull Moose candidate in 1910 who first proposed that all Americans should have health insurance. We're about 100-year anniversary would be a good time to get it done right. So, 785-777-773. Yes, there's a hand right there, 2 hands. I see 2 right in the middle. Microphones, please. 2 in the middle. Here we go. It's an awkward layout, I'm sorry, but this is the best room we could get on, fairly short notice. Go ahead.
First off, I'd like to thank you for opening up a meeting so that we all can voice our opinions. And I also would like to say I appreciate all of your bills that you're passing to keep Oregon's beautiful scenic areas safe and for generations to come. I am not in favor of any bill, regardless whether it's healthcare or anything, that involves 1,000 pages and more that people don't read in Congress, or if they do read it, they don't understand what the heck they read. And also, we are being, certain countries are being pointed out as great examples of government-run healthcare. All right, I listen to news channels, many of them, all over, not just one. And I was listening to ABC News Monday, and they reported that France has been operating in the red since 1989 with their government-run healthcare, and they're now looking to us to help them solve this problem. Also, CNN reported that 52% of Germans don't like their single-payer system that they're now under and wish it was not there. I also have watched some things on Fox by Daniel Hanahan, who is a European...
Come on, let her speak, let her finish.
Who is a European Parliament member, and he says that the system in Britain has led to rationing of many healthcare services, especially to their seniors. Now, and I also will say this, so I think that we do need changes so that people of all income levels in this country can buy insurance. But I don't see us having to fix it in a big hurry and not taking time to look at it. And I will say this, single payer healthcare will not make people healthier. What will make people healthier is looking at their diet and getting enough exercise. It's an individual responsibility.
Well, you're right about the wellness and people looking at nutrition and diet and those things, and this bill proposes that insurance plans should cover those services, which are not routinely covered in a lot of plans now. And a lot of times your doctor isn't, I'm not, probably some doctors here are going to get in trouble, but most of them are not really tremendously versed in nutrition issues, shall we say. That's a nice way to put it, and nutrition specialists and others can do better. And another thing that it seems to me, which goes beyond that, when I was a kid, we had the Presidential Fitness Challenge program. You had mandatory PE. Most of our schools don't have PE anymore. Kids got to pay to play sports. I live in Springfield. They just jacked up the price in the middle of recession for kids to play sports. I mean, they had to, but that's not right either. And so, I mean, there's some things that go to lifestyle need to change. But on a couple of points, I mean, you know, we do ration healthcare today in a very inefficient way. As you pointed out, there's a lot of people don't have insurance, and they can't go and get, when something starts to happen, they can't get care. But then they end up at the emergency room. It may or may not be a lot more expensive. I'll give one quick example. A friend of mine was before the Oregon Health Plan covered pregnant women. In the old days, the plan before it's called the Oregon Health Plan would cover you after you had a child, but not before. And so this young woman didn't get to consult with an obstetrician, had a condition that could have been dealt with for a couple of $1,000 probably. She ended up in McKenzie-Willamette being hospitalized for a long period of time. Both she and her baby were very ill. Long-term prognosis, probably okay, but not great, and it cost $60,000, and we'd pick up that tab. We need to get people in at the front end to get them those kind of services, and we'll all, in the end, have a healthier society and do better. And I think the disagreement is over how do we fix that, and that's why we're having a robust discussion. From my perspective, in terms of the bill, I think it could be simplified. I think it could be written in a way that's less turgid. You know, they sort of specialize down at Ledge Council in writing things in ways that are very obscure, and so, you know, my position is going to be when we finally get to an agreement, if we get to an agreement, that whatever it is we agree on should be explained in a section by section, simple English language, you know, version, and it should be out there for some time before we vote on it so people know what it is and they can comment on it. So, yes, ma'am.
Hello. I am for single payer, and my father is a very conservative Republican, and he's not for that. But there's something that we really agree on, and I'm hoping you can speak to it. And what we both found is that there are no standard prices. So for example, I had to get an MRI last year, and it was $1,900. But it turned out my insurance company, I'm self-employed and I pay for insurance, had negotiated a $700 rate. So if I hadn't had insurance, I would have paid $1,900. My father was in the Peace Corps in his 60s, and he needed an operation. And when he came back to America, they wanted to charge $5,000 for it, and the Peace Corps said that it cost $1,200. So it ended up costing $1,200. And I frequently ask my physicians how much something costs. And except for my rural doctors, nobody can tell me. So I'm wondering whether it's a public option, whether it's, I don't like the idea of a co-op, but however, how do we help create standardized prices, like when we shop for other things, so that as Americans we can be personally responsible, but we can also make sure too that we aren't getting ripped off.
Well, I'm not sure we can standardize the prices across all plans, but what we can do is certainly have that the prices are known, and the plans that that people would be looking at who don't have insurance today would tell them, well, here's these kinds of procedures are available under our plan. Here's what they cost. Here's what you'll pay. It could be a lot less opaque than it is. I mean, it's a totally opaque system because the way it works now is it's really based on there's two things. One is utilization. I recommend anybody who wants to see what some of the problems are in healthcare, that New Yorker article from last spring about McAllen, Texas, where some private physicians have got a private hospital and they have private testing facilities, and the average Medicare rate in that town is more than twice what it is at the home of the Mayo Clinic, where people arguably are getting some better care. And they talk about its utilization. That's how, I mean, every procedure has a price, and the more procedures you can order. Now, some say that has to do with issues about torque, but a lot of it is some people have figured out how to game the system. So we need to revise, and that's proposed, and that is not yet settled. There's something called MedPAC, which has been proposing reforms to the way we pay for health care in America for a long time. They're generally ignored by Congress. And some of us have been advocating that MedPACs, we should have to vote on their recommendations, which go to issues of moving from something that's based in the number of procedures you can order to something that's based in the outcomes that you get with these procedures. And so that you remove the incentive, but you reward good outcomes, actually. And the bill does include some provisions here where hospitals that have high readmission rates very quickly after someone's had a procedure, are going to be looked at, and those that don't have a lot of readmissions, and this is not rationing care, it's just sort of, does your doctor send you back and did they do things right? Those sorts of things would be encouraged, sort of best practices. So, I mean, you're pointing to a problem, but the other point is individuals have no buying power in this system. You just don't. I mean, the people who pay list price for drugs are the people who have no insurance. And list price, no one can afford for drugs. And every insurance plan negotiates lower drug prices. The VA negotiates lower drug prices. The Canada and every other nation on earth, whether they have a public plan or whether they have private insurance, the country negotiates the lower drug prices for everybody in that country, whether it's a private insurers or public insurers, because no one else has enough clout to deal with this industry. But we in America are, we're getting, some of us are in private plans, are getting some fairly decent prices on drugs, but Medicare Part D is paying very high prices. It was actually outlawed, the government, from negotiating lower prices, and then gave seniors a donut hole, which is catastrophic for some seniors. We could go back, repeal that provision, negotiate lower drug prices for all seniors, lower their premiums dramatically, simplify the program, and save $40 billion a year. I mean, that's, so we have to recognize that there are powers can only be dealt with, at a high level, in that case, pharmaceuticals with the government, and in the case of individuals, we got to get people into groups. That's where you get your discounts, and that's the whole basis of this plan, is to get people into groups where you get the negotiated discounts in those plans. So but those are excellent points, and it's amazing to think of that price differential. So, I'm forgetting my thing here. 942 818-942 764-618-942. Yes? You want to? Okay. Why don't you we'll get a microphone to you as soon as we can, but if you speak up, I can repeat it. Okay.
I'm here as a member of the Legislative Action Team for Planned Parenthood Oregon.
Okay, here comes the mic. So here you go, right there. There you go. Great. Okay, go ahead. Let her have it.
I have concerns about the inclusion of reproductive health services in any healthcare proposal that is now provided. Even under private plans these days, many women can't afford their health care, in particular health care associated with reproductive services, because their co-pays are so high, because prescriptions are so high. Exactly the sorts of things that you've been talking about. So that's what's brought me here today. But as I've been listening to you talk, I keep thinking about the stories that have been told in the progressive press about healthcare debates over the last number of months regarding the discrepancy between what people say can be done in Congress, what's doable, what's negotiable, what we can compromise on, and what the American people seem to be clamoring for. There's this enormous gap. On the one hand, Congress and the administration is terribly constrained by all of these things that seem to have very little to do with popular opinion or the popular will. What can we do? I like everything I've heard you say today, not just about healthcare, by the way, but I'm here to speak about that. What can we do? We are a group, and I'm not talking about buying healthcare or buying insurance right now. I'm talking about buying political clout around this particular issue. What can we do to help you speak up, be heard, and make a difference?
Thank you. Well, look at the turnout we got here. That's phenomenal. I mean, if you have an opportunity, go to meetings of your elected officials and speak out. If you don't have an opportunity to do that, join a group that's advocating, that gets some access. Send individual emails, phone calls. There's all your sort of standard lobby techniques. And a lot of times there's people out there who think someone else is going to represent their position and take care of the problem. I mean, we're all busy in our lives. Don't assume that about something even as critical as healthcare, that someone else is going to represent your views, your interests about what we need in a good healthcare plan and where we should go with it. That is something that we've all got to be involved with individually. And I mean, there's been a lot of chatter on the national networks about a few extreme examples. This is my 10th meeting, and I found people have different opinions, but everybody realizes healthcare is critically important. There seems to be people coalescing around the idea, yeah, there's holes in the system now, we got to plug them somehow. We got to, and then after that, people start to really kind of move in different directions. But that's something to build on. And one thing I recommended during the debate before we finally got a deadline, a timeline to get out of Iraq, when people were saying we need a timeline to get out of Iraq, I said I support that, but what you've got to do is go talk to people who don't agree with you and see if you can bring them around to your opinion and get them to change. So part of it is educating our neighbors and our communities and getting them involved too, and even talking to people that you disagree with and see if maybe they can agree to some of those concerns that you have, and we can make more common cause. Best, sort of basic. Jim Klonowski should be here. He could tell you better how one gets things done, but we still his spirit is still with us. 804.
Peter?
Oh, I'm sorry. Okay, yep.
Yes, I hold dual citizenship in New Zealand. New Zealand's the poster child for the free market, but they made a decision to keep healthcare outside a for-profit model. So I don't have to pay for any healthcare services. If I do decide to go privately, they are at least 10 times less than the same service or goods that I would pay for in the United States. You began to address it in terms of the pharmacies, but it has to be addressed all the way around. We're using the word cost, or we're hearing the word cost, to have two components, the fees and the charges and the payments. And that's not being clear to people. People need to understand that the fees and charges by all healthcare industry, including insurance, is hyperinflationary and is in the for-profit market. The other thing in New Zealand is that medical misadventure is no fault. So this idea of addressing medical malpractice in the United States is really essentially important. So I feel that it's really important for you to help the administration begin to explain to people that they are paying exaggerated fees and charges for goods and services compared to other countries which you recognize are negotiating on behalf of their citizenships for the same services, but at not an inflationary fee and charge.
Okay. No, the woman in the middle there mentioned earlier, sort of seeing the survey on the different networks. A lot of them running it. You can find it online and that. But if you do look around the world, there are a mix of single payer, mixed private, public, and private plans in the insurance of our major industrial competitors and other democracies. And what you will see is that basically our health care is twice as much as the nearest, and our outcomes are not better. In fact, we're down in the 20s on infant mortality. Our longevity is not longer. We have, if you can access our health care at a technical level, it's the best in the world. But we don't do really well at getting more people into the system, maintaining their health, preventing disease, and doing those things. And that's part of where we see big savings in this bill, is getting people easy access and not having to wait until it's absolutely critical, then go to the ER and say, gee, you should have been in here 2 weeks ago. We could have fixed that pretty easy, but now, I don't know. So, and that's one thing that some other nations have resolved, and the pharmaceuticals are particularly a pet peeve with me. I'm very much against the deal that was cut with them. They're proposing to take somewhere around, they will contribute 2.5% of their annual profits to help resolve the health care issue. This is a deal that was cut by Max Baucus from Montana, who also was the Democratic cooperator with the Republicans on Part D. And he took this to the White House, and the White House says they've signed off on it, but I tell you, there's nobody in the House has signed off on that deal. Pharmaceutical industry's got to put a lot more on the table in this debate. So thank you very much for that thought. So, okay, we've got another one somewhere. Yes, go right ahead.
Mr. DeFazio, I'm a registered independent, and I really applaud you and all your work that you're doing for health care, because I know that a lot of people need health care. However, there's one thought that keeps, I'm very concerned about this, is that many Democrats in the past years during political races are accepting thousands of dollars from Planned Parenthood.
And I don't think they may have a political arm, but Planned Parenthood itself is not allowed to contribute money. They may have they've got C3s and C4s and stuff, so I don't know. But I mean, the group itself, as a medical care provider, cannot, reproductive health services provider with a nonprofit status can't give political contributions. But go ahead.
But I seen on this last year, I seen different, and I won't use names, people who listed as contributions towards their campaign Planned Parenthood. Now, this is an organization that does like almost 300,000 abortions in year 26-27, received 325,000 in 06-07. And I kind of wonder, when these people, and a lot of them are Democrats, are receiving this money, are they obligated to vote accordingly in issues in Washington? Are they pawns?
Oh, sir,
all I'm doing, Peter, is trying to say, I'm standing up for the children who lost their lives through abortion. That's what I'm saying.
This is obviously an ongoing and deeply held debate of whether we'll go back to a time I remember when abortions were outlawed and women who got abortions were criminals or had to go to foreign countries, and it wasn't too good of a time. So, I don't think there's anybody who wants to see a lot of abortions, but 80% of the health care plans provide reproductive services, private health care plans, including up to abortion. And under this bill, that isn't going to change. So there's no undue influence being exerted here. Really no change in that balance under this plan. It does say specifically that in the exchange, there must be a plan that, offers reproductive health services, and there must be a plan that does not offer abortion services, so that people of conscience can go to that plan if they're opposed. And so that provision was made. So I don't think you're seeing undue influence here. It's really not going to change the current debate or the levels of the debate.
Well, I don't think it should be
we have
classified as healthcare.
358, 672. Oh, we have another one over there? Okay, all right. Okay, thanks.
Thank you. My name is Lee Finley, and I have a question. I heard a rumor that in Congress there was a bill being introduced concerning a hate crime bill. Is this true, or can you enlighten us on that?
There's been hate crimes legislation pending for a number of years in Congress. It pretty much grew out of the horrible murder of Matthew Shepard, and our former Senator Gordon Smith was a big supporter of it, as were most other members of the delegation. There has been some hate crimes adopted at the federal level, and there may well be some more legislation in this Congress. So, okay, is someone down there?
We've got a question over here.
Okay, go ahead.
I would like to thank you very much for your no vote on the cap and trade. The question that I have is that you mentioned that it was hard for you to get the antitrust across the aisle. A Maxine Boardman from Minnesota, I don't know if I pronounced her name right or not, was on CNN saying that they have an alternative to single payer where it would be the antitrust. She had a whole plan that way that she couldn't even get the ear of the leaders of the Democratic Party to even consider it. Mm-hmm. And why can't the two parties get together and even discuss it? There's quite a few people, even some Democrats, that agree exactly what you said about the antitrust and tort reform, and and have the government be a real strong oversight, not a single payer system, and it could accomplish the same thing. That was her plan.
I'm not familiar with her particular plan, but I'm always, as I mentioned earlier, I've worked closely with Ron Paul on a number of things and others. I'm always happy to have. I've put out a letter to every member of Congress, several, asking them to join me on my antitrust legislation, both in the last Congress and this Congress. And I tell the truth, I'm not even sure. I think I may have some Republican sponsors. I don't know if she's on it, but I will seek her out when we get back and see if she wants to join me in that effort, because I don't see how anybody can say this one particular unbelievably powerful industry, which plays a role in our daily lives, should have the right to be exempt from the same rules that other businesses have to play by. And the Consumers Union says it isn't just health care. They say we would save $40 billion a year as consumers if the insurance industry stopped colluding and had to compete. That's car insurance, homeowners insurance, liability, all lines of insurance would be cheaper if we did that. So we're going to, do you have someone there? Okay.
We have another one on your left. On your left.
What? Oh, sorry. I can't. It's a big. Yes. I called a bunch of numbers and they're apparently.
This is an old one.
Okay.
Quite a while ago. I'm 61. My husband is 59. Since he was laid off last year, our insurance coverage has come through COBRA. I'm self-employed, so no insurance there. If my husband doesn't find a job soon, we'll be kicked off COBRA. Our only option then will be age-rated plans with larger premiums and less coverage. I understand that all the bills out there in Congress continue to allow age-rated pricing. Is there any provision in any of these bills to allow people to keep COBRA for a longer period, say until eligibility for Medicare? Perhaps back to Medicare, back to 60. This is particularly important to all of us over age 55.
Sure, thank you. No, you're pointing out a huge gap in the system, particularly in the discrimination against older citizens. There's a couple of points. One is on COBRA. I'm glad you're able to, since you're working, you can afford to pay the premiums. I've talked to a lot of people who have been unemployed and they're offered COBRA. One gentleman who I met at the unemployment office, his COBRA was $850 a month. His benefits were $1,300 and his wife was very ill. So he's choosing between giving up his house and losing everything or getting his insurance and struggling by. So that system needs to be improved dramatically. And then also under COBRA, all the Monaco employees were paying their half of the premium, but it turned out the bankrupt company wasn't. They all got, many of them got procedures, including some very expensive procedures. They're now being told they're going to have to pay. So there's big gaps there. The age rating of this bill here, again, it's a work in progress. It says that you can't discriminate more. Currently, an age-rated premium can be 4 or 5 times as much. The bill, and this is nothing that I'm going to particularly defend or understand, I guess this was done in one of the committees that has a lot of experts. They said they thought a 2-to-1 discrimination was reasonable. So they would limit it to 2-to-1. But then the idea would be there would also be the public plan option, which theoretically would. So anyway, that's still a work in progress, and this is a huge, huge gap, and I'm very aware of our people in that age group. Too young for Medicare, too old for a lot of private plans, and it's a big problem, but we've got to deal with that. So, okay, that'll be that gentleman, and then we're getting to 6:25 after Springfield at 7, so this is probably the last question. Go ahead, sir.
I've heard a lot this evening about the high cost of commercial insurance. However, what I don't hear anybody talking about is the fact that one of the reasons, or some of the reasons that there is a high cost for commercial insurance is state mandates for particular coverage that people may or may not need. We also have a problem with government health plans, Medicare, Medicaid, TRICARE, that don't cover the cost of the services that they purchase, and so there's a transfer of those costs to the commercial health plans. So if you're operating a hospital, you're operating a physician's practice, you couldn't make it on what Medicare or Medicaid or any of the government health plans reimburse. You rely on that transfer of cost to the commercial healthcare system. Is there anything that's going to be addressed in this health plan that'll do that? Because government, when they talk about controlling costs, what they talk about really is controlling reimbursement. And if you reduce reimbursement, you reduce services, and now you're going to have physicians dropping out of practice, you're going to have hospitals closing down, you're going to have problems like that. Thank you.
Well, I talked about that a little bit at the beginning, and when I talked about the geographic disparities in Medicare. And we are being discriminated against, and it is particularly hard for seniors, and there is a lot of cost transference in Oregon because of those low rates in 16 other states. We're going to bring down some of the over-reimbursed states, and we're going to bring up those 17 states, and that will begin to resolve some of that issue of cost transfers. Where I would like to go also would be that we negotiate, as I said earlier, lower pharmaceutical costs for everybody in America, and that would go your insurance company or your public plan would start at a much lower wholesale price than they do today. That could save us a heck of a lot of money, and what the industry says is, look, America's the only place where we make big profits. And so I'm thinking, well, maybe they need to negotiate a little harder with those other countries and maybe get a little more out of them and not price gouge, which is what's happening when the same drug costs 2 or 3 times as much in the U.S. as it does in Canada, maybe by the same company right next door. So there are some issues there that I grant you need to be dealt with, and cost transference, I talked at the beginning, $1,400 of your policy goes to pay for people who don't have care. now because they go to the ER and the hospital has to get that money somewhere, or the doc has to get that money somewhere, and it goes to the private pay people. And I acknowledged that at the beginning. Not much of that goes over to those public plans, and that's one of the issues we're trying to deal with here. Been a great audience. Thank you very much. I appreciate it. Thank you.